introduction. Good morning, ladies and gentlemen. I thank the organizing committee for giving me an opportunity to deliver a lecture on today on this CME on Sono Air 2025. Securing an airway is the responsibility of the anesthesiologist, be it in an emergency situation or while delivering or administering anesthesia. Most of the time it is easy to secure the airway, but there are situations when it becomes difficult. I will be talking basically on the anatomy of the upper airway and endotracheal intubation. Difficult intubation or difficult airway will be dealt by the subsequent speakers. Now, introduction. When you can't breathe, nothing else matters. You have to secure the airway in that patient and see that he is able to breathe so that oxygen reaches his tissues for metabolism. Now, airway is primarily a conducting pathway and the core of care of anesthetized and unconscious patient, because airway has to be secure and patent so that oxygen from the atmospheric air or from the anesthesia machine can reach the patient. Now, it is paramount to safe perioperative care. Even in the post-operative, the patient, you have to ensure that the airway is kept patent. Most of the time, it's straightforward at much of the time, and it can be very difficult sometimes. The depressant effect of the airway is an immediate threat to the patient. Now, it requires a range of manual skills as well as knowledge to ensure a patent airway. You must have heard of the S-March maneuver, the Rubens maneuver, and the triple airway maneuver, where manually one can secure an airway in an unconscious patient. Now, the airway undergoes growth and development. In the pediatric age, it is at a higher level and anteriorly placed, whereas in the adult, it goes little posterior and at a lower level. So there are significant changes in the size, shape and relation to cervical spine between infancy and childhood. 1/3 of all the adverse anesthetic outcome is related to respiratory complications, and difficult intubation is one of the important mechanisms. Now, coming to the anatomy. Now, the airway refers to the upper airway. The upper airway comprises of the nose, the nasal cavity, oral cavity, the pharynx and the larynx. Below that is the lower respiratory tract, which includes the trachea and the main bronchi and the bronchioles. So this picture over here is showing you the anatomy of the airway. If the larynx is the upper airway, and below that the trachea and the major bronchi is the lower airway. Again, this is showing us the nasal cavity, the nasopharynx, the oropharynx, and the laryngopharynx or the hypopharynx. Now, the nose and the nasal cavity. The nose is the airway which moistens and warms the air, filters the inspired air, and it is a resonating chamber for speech, and also it serves the purpose of olfaction, that is sense of smell. Now, the nasal cavity is divided into two halves by the nasal septum. The entrance of the nostril is covered with skin and hair, and the lateral wall has three bony projections called the turbinates, the superior, middle and the inferior turbinates. Then the external meatus is a triangular shaped projection in the center of the face, and the external nostrils, these are the two chambers which are divided by the nasal septum. The septum is made up primarily of cartilage and bone and covered by mucous membranes. The cartilage also gives shape and support to the outer part of the nose. The nasal passages, these are the passages that are lined with mucous membranes and tiny hairs called cilia that help to filter the air. Then the sinuses, there are 4 pairs of air-filled cavities also lined with mucous membrane. You have the frontal sinus, you have the maxillary sinus, you have the ethmoidal sinus and the sphenoidal sinuses. Then the nasal cavity, as said earlier, is divided into left and right halves by the nasal septum. What is the nasal septum formed of? It is formed above by the perpendicular plate of the ethmoid bone. Posteriorly is the warmer bone, and anteriorly you have an extensive cartilage which is quadrangular in shape. Now coming to the oral cavity. The oral cavity is also a conduit for air and food. It helps in pharyngeal phase of deglutition. It helps in appreciation of taste, provides a local defense and immunity, and forms part of the vocal tract. Then the tongue is on the floor of the oral cavity. The muscles of the tongue, you have the intrinsic muscles which act to change the shape of the tongue and arranged as longitudinal, transverse and radial fibers. You have the superior longitudinal, the inferior longitudinal, the transverse and the vertical muscles. Those are the intrinsic muscles. Coming to the extrinsic muscles, you have the genioglossus, you have the hyoglossus, the styloglossus and the palatoglossus. All the tongue muscles are innervated by the hypoglossal or the 12th cranial nerve. Now coming to the pharynx. Pharynx is a fibromuscular tube extending from base of the skull to become continuous with the esophagus. It is about 12 to 14 centimeters in length. It is broadest at the cranial extent and narrowest at the esophageal junction. Now the boundaries are, the anterior is not complete, it opens into the nasal or the oral and laryngeal cavities. Posteriorly, it approximates the C3 to C6 cervical vertebrae. And the superior, it is attached to the basilar part of the occipital bone and body of sphenoid bone. Laterally, it is fixed to the medial pterygoid plate, the pterygomandibular raphe and the lateral aspect of the tongue. Pharynx is divided into the nasopharynx, the oropharynx, laryngopharynx or the hypopharynx. Now coming to the nasopharynx, it acts as a conduit of air, ventilates the middle ear through the eustachian tube. Elevation of the soft palate cuts off the nasopharynx from the oropharynx during swallowing. It acts as a resonating chamber during voice production. The boundaries of the nasopharynx anteriorly, it is the posterior nasal aperture or the choana. Roof is formed by the basi-sphenoid and basi-occiput. Floor is the soft palate anteriorly and which is deficient posteriorly, and laterally it presents with the opening of the eustachian tube, the torus, tuberous and fossa of Rosenmuller. The fossa of Rosenmuller is the common site for most of the cancers in that nasopharyngeal area. Coming to the oropharynx, it is relatively uncomplicated, leads into the laryngeal pharynx or the hypopharynx, extends from the soft palate to the cranial aspect of epiglottis, anteriorly begins at the oral cavity via the oropharyngeal isthmus, and the lateral wall presents the palatine tonsils, the palatoglossal and the palatopharyngeal arches. Then comes the laryngopharynx or the hypopharynx. It is the lowest part of the pharynx, lies behind and at the sides of the larynx, lies opposite the C3 to C6 vertebrae. The superior limit is the body or the hyoid, the posterior pharyngeal wall, and the inferior limit is the lower border of the cricoid cartilage. It is divided into 3 regions: the pyriform fossa, which extends from the pharyngoepiglottic fold to upper end of the esophagus, the postcricoid region between the upper and lower border of the cricoid laminae, and the posterior pharyngeal wall. Now, what are the muscles of the pharynx? You have the superior pharyngeal constrictor, constricts the pharynx, the middle pharyngeal constrictor also constricts the pharynx, and the inferior pharyngeal constrictor which also constricts the pharynx and prevents reflux of esophageal contents into the pharynx. Then you have the stylopharyngeus, elevates the larynx and pharynx. You have the salpingopharyngeus, which elevates the pharynx and opens the auditory tube during deglutition. And then is the palatopharyngeus, which elevates the larynx and pharynx and closes the oropharyngeal isthmus. Now, what is the arterial supply of the pharynx? It is supplied by the ascending pharyngeal branch of the external carotid artery, the pharyngeal branch of the maxillary artery, the ascending palatine and tonsillar branch of facial artery, and the superior and inferior thyroid artery. The venous drainage is through the pharyngeal plexus, draining into internal jugular and the facial veins. The nerve supply of the pharynx, the sensory supply is by the maxillary division of trigeminal and glossopharyngeal nerve, which supply the nasopharynx and part of the oropharynx. And the glossopharyngeal and vagus nerve supply the remainder of the pharynx. Now coming to the larynx. Larynx, or this sound box, you generally call it. It is formed of three single cartilages and that is unpaired cartilages and three paired cartilages. So it lies in front of the hypopharynx, opposite again the C3 and the C6 cervical vertebrae. The length is around 44 millimeters in the males and 36 millimeters in the females. It moves vertically and antero-posteriorly. Consists of cartilages, ligaments and muscles. Now this is showing you the airway, the upper airway, which extends to the larynx. Right, is the larynx. You have the nasopharynx, you have the oropharynx, and then the hypopharynx. This is the upper airway. Now, cartilages of the larynx, the three paired are the arytenoid, corniculate, and the cuneiform. Whereas the unpaired are the thyroid, which is the largest, the cricoid, which is the only true ring, and then is the epiglottis. Coming to the ligaments of the larynx, you have the thyroid membrane with a middle and two lateral hypothyroid ligaments, the cricothyroid membrane, the hyoepiglottic ligament, the cricotracheal ligaments, the posterior cricoarytenoid ligament, and the thyroepiglottic ligament. What are the extrinsic muscles of the larynx? In the suprahyoid region, you have the anterior belly of the digastric muscles, which draws the hyoid forward. Then you have the posterior belly of the digastric muscles, which draws the hyoid back. Then you have the geniohyoids, which elevate and advance the hyoid and lowers the jaw. The stylohyoids, they raise the hyoid and larynx and also fixes the hyoid. Then you have the mylohyoids, which raise floor of mouth and hyoid, and it lowers the jaw. Then the subhyoid muscles are the omohyoids, which lower the hyoid, opposes the upward movement of the larynx. Then you have the sternohyoids, lower hyoid, it lowers the hyoid and opposes upward movement of the larynx. The sternothyroids, they again lower the hyoid, opposes upward movement of the larynx. And lastly, you have the thyrohyoids, which lower the hyoid and raises the larynx if hyoid is fixed. Now, what are the intrinsic muscles of the larynx? You have the cricothyroid muscle, which tightens the vocal cords, posterior cricoarytenoid muscle, opens the glottis, lateral cricoarytenoid muscle, that narrows the glottis again, the thyroarytenoid muscle, which controls the tension of the vocal cords, the transverse and oblique arytenoid muscles, which close the glottis. This reminds me of my undergraduate days where in anatomy one had to mug up everything. It's difficult to remember all these names. Then you have the internal thyroarytenoid muscle, which raises the pitch of voice, relaxes the posterior parts of the vocal ligaments, while the anterior part is tense. You have the airy epiglottic muscle, narrows the laryngeal inlet by bringing the airy epiglottic folds together. And then the thyroepiglottic muscle widens the laryngeal outlet by depressing the epiglottis. Now, what is the nerve supply of the larynx? This is very important. You have the recurrent laryngeal nerve, which is the branch of the vagus, which is sensory below the vocal cords and motor to all the intrinsic muscles of the larynx except the cricothyroid. Then you have the superior laryngeal nerve, again a branch of the vagus. It has the internal laryngeal, which is sensory above the vocal cords, and the external laryngeal, which is motor to the cricothyroid. Now this is the diagram which is showing you the trigeminal nerve with the ophthalmic branch, the maxillary branch and the mandibular branch. Then you have the glossopharyngeal, the ninth cranial nerve, and then the vagus nerve, which has the superior laryngeal, the inferior laryngeal and the recurrent laryngeal branches. Coming to the blood supply of the larynx, it is supplied by the superior laryngeal artery, which is branch of the superior thyroid from the external carotid, and the inferior laryngeal artery, which is from the thyrocervical trunk. Now coming to establishing a patent airway. Well, I just mentioned to you about the manual maneuvers. You have the chin lift and the jaw thrust maneuver, that is the Rubens maneuver and the Eschmarsch maneuver. And then you have the triple airway maneuver, which is head tilt, chin lift and the jaw thrust. Then you can establish a patent airway with a oropharyngeal airway, a nasopharyngeal airway, and then the laryngeal mask airway. The above do not protect against aspiration and laryngospasm. Mask ventilation, it can deliver a high FiO2, it avoids the potential trauma of intubation, does not protect against aspiration, and may result in gastric distension if not properly held. Laryngospasm can occur and requires use of both hands. Now, preoperative evaluation is very important to detect a difficult airway. So, physical examination includes the tongue versus the pharyngeal size. You have to see the atlanto-occipital joint extension movements. You have to see the cervical spine mobility generally is around 35 degrees. The anterior mandibular space, the thyromental distance, normal is 6 centimeters. Then you have to also see the dental examination for loose teeth and the prosthesis. Now this is how it is showing you how you check for an airway. So initially this is a distance from the chin's inner rim to the hyoid bone should be around 3 fingers breadth in adult. If you can only fit 2 fingers, then you can expect an anterior airway. And from the side, if you see the patients with less than 2 finger breadth often appear to have a hypoplastic mandible, that is a receding chin. Now when you take an anterior larynx, in an anterior larynx you will see that the larynx appears anterior to your field of view. Here you see only the arytenoids. Often you see no landmarks and making the intubation difficult. Now checking for the mobility of the adult jaw. If she can open her mouth wide enough for 3 fingers, then it's adequate. If not, you won't have room to insert your laryngoscope plate and visualize the larynx. So this generally occurs in cases of trauma, arthritis, tumor or infection, which can limit the mouth opening. Then you ask the patient to have her place the lower teeth opposite the upper teeth. Check for the ability of the jaw to glide forward. This ability is often lost or restricted in patients with arthritis. Before ability to open the mouth is lost. Now Mallipati signs as indicators of difficult intubation. You are well aware of all these signs. You have the class 1, class 2, class 3 and the class 4. Now what are the indications for intubation? 1 is anesthesia and surgery. 2 is for a ventilatory support. 3 is for protection of the airway. 4 for ensuring airway patency. And lastly for suctioning. Now what are the contraindications for oral intubation. Those are generally the indications of nasotracheal intubation. Like in surgical avoidance, mouth surgeon is also going to share the same place, so there you'll have to go in for the nasopharyngeal intubation, nasotracheal intubation. Then poor oral access like trismus, fractured mandible, cervical spine fracture, and the temporomandibular joint arthritis. And in cases of prolonged ventilation of where a nasotracheal intubation is better compared to the orotracheal intubation. The other contraindications to the nasotracheal intubation are bleeding diathesis, a nasal pathology which includes the infections, polyps, epistaxis or a deviated nasal septum, and fracture base of the skull and nasal stenosis. Now what is the technique for orotracheal intubation? Well, one has to make preparations and check your equipment. So always have a suction available. The head position, you have to align all the three axes, the oral, the pharyngeal and the laryngeal axis. The choice of the laryngoscope and endotracheal tube you have to make, whether you want the 3-size blade or the 4-size blade. Endotracheal tube, whether you want the normal one or you want a flexometallic, that you have to decide depending on the surgery. Possible need for awake tracheal intubation, there you should be ready with your difficult airway algorithm. Now preparation includes 100% oxygen with high flows up to 10 liters per minute, a suction apparatus, intubation tray which consists of 2 laryngoscope handles with variety of blades, oral and nasal airways, variety of endotracheal tubes, syringes, tight stillet, KY jelly, you have Meckel forceps, keep of the tape, you should have towels, local anesthetic solution and the laryngeal mask airways. So all these preparations are to be made before going in for an intubation. Coming to positioning of the patient, the sniffing position with flexion of the neck and extension of the atlanto-occipital joint, you have to keep a folded towel or a pillow about 2 inches thickness below the occiput, which will and tilting the head backward manually. Then sniffing position was given by Sir McGill. Now the 3-axis alignment, as earlier told, the axis of the pharynx, the larynx and the mouth have to be brought in alignment, making the line of sight and all axes in the same direction. Now this is showing you the 3 axes of the larynx, the oral axis, pharyngeal axis and the laryngeal axis. This is in the neutral position. In the sniffing position, what happens? The laryngeal and the pharyngeal axis come closer to each other, but the oral axis remains still vertical. But when you do the extension of the head at the atlanto-occipital joint, the 3 axes more or less come in the same line. Now orotracheal intubation, you have the patient's head at the level of the xiphoid. Ensure a sniffing position. You have the laryngoscope in your left hand. Open the mouth. Hold tracheal tube in right hand like a pencil. This is just like teaching children. Anyway, people have been doing it. So this is the correct position of the endotracheal tube. The cuff should be below the vocal cords and the tip of the endotracheal tube should be in the midway in the trachea. So like it is showing, cuff is below the cords and tip about mid-trachea. This is the proper positioning of an endotracheal tube which lies above the carina. If it is touching the carina, the patient will keep bucking. So you should avoid pushing the tube that much in that it goes and hits the carina. Then what are the common errors? Don't leave the blade in the middle of the tongue. Sweep the tongue to the left. Generally you enter from the right hand side for a left-handed person and you take the tongue away from the midline to the left side. Then push the blade as far to the left as possible to leave room to see the larynx and pass the tube. Then you should lift upwards. Don't push on the teeth. And keep your wrist stiff, elbow straight, lift upward, don't rotate towards yourself. Try to avoid injury to the upper lip of the patient and the lower lips. This is showing you the proper laryngoscopic technique. You have to lift the tongue forward, the laryngoscope should be taken forwards, upwards, not right upwards. It should be forwards and upwards. Now this is an awkward technique. Most of the time you find some of the anesthesiologists looking into the mouth. You should not bend that much low. Stay straight. Don't stoop or bend your arm. You lose the mechanical advantage, the binocular vision and the maneuverability. This is an awkward position. Now exposure, to prevent exposure, you should have gloves are recommended for opening the mouth, anteriorly displacing the mandible and soft tissue of the oral cavity and neck with your laryngoscope. You use the scissors maneuver to open the mouth, and there is also the no-touch technique. Now visualization, you advance the blade until the uvula and the tonsillar folds are seen. Displace the tongue to the left. Advance the blade till it lies in the vallecula. Pull it forward and upward using firm but steady pressure. Not only upwards, forward and upwards. Avoid leaning on the upper teeth. In most situations, the vocal cords should be visible. Gentle pressure over the cricoid area may help to better visualize the glottis. The endotracheal tube insertion at the right corner, put it through the right corner of the mouth. Occasionally rotate the tube to 90 degrees to the right or left. The cuff should go beyond the cords and advance another 2 to 3 centimeters into the trachea. Cuff inflation. Inflate the cuff with the required amount of air. There should be an audible leak at 20 centimeters of water pressure. There should be no overinflation of the cuff, which will lead to ischemia. Continuous cuff leak is due to a damaged cuff or tip of the tube may be below the vocal cords, but large portion of the cuff lies above the vocal cords. So in such situation, there will be a continuous cuff leak. Now for confirmation, you have to see the symmetric chest movement, the symmetric breath sounds. The end tidal carbon dioxide is the gold standard, greater than 30 for 3 to 5 breaths. The condensation of water in the tube is also a confirmation of the endotracheal tube being in place. Palpation of the cuff in the suprasternal notch, and then fiber optic bronchoscopy also will help to confirm whether the endotracheal tube is in the trachea. Then the other methods by direct vision, ultrasound imaging, which they will be talking later, I think, on ultrasound. Then the negative pressure test, you have the tube marking, the movement of the reservoir bag, sternal compression, transtracheal illumination, vocal silence, awake intubation, the pulse oximetry and the X-ray chest. These are the other ways to confirm placement of the endotracheal tube in the trachea. Now for stabilization, patient should be generally sedated, not paralyzed. Stabilize to the maxilla, not to the mandible, as the mandible is mobile. You make use of the adhesive tape. Sometimes the tape may not be adequate. You will have to use some other method to try it, stabilize it. Now what are the false negative results, which results that tube is in the trachea and the capnogram suggests that the tube is in the esophagus. So this can occur in cases where there is a severe airway obstruction. There is concurrent peak and endotracheal tube cuff leak in low cardiac output states, in severe hypotension, in pulmonary embolism and advanced pulmonary disease. So these are the false negative results which you will get in such situations. And the false positive results where the tube is not in the trachea but still the capnogram suggests that the tube is in the trachea. This occurs when you have done a bag wall mask ventilation prior to intubation. Then patient has antacids in the stomach, recent ingestion of carbonated beverages and the tube in the pharynx. Now suspicion of esophageal intubation, indications for extubation, poor or no chest movements, there's a failure to oxygenate, patient develops cyanosis, there's tachycardia and hypertension, absence of condensation in the expired gas, and the CO2 not detected by the capnographer. Situation, we have to take out the tube and then again attempt for re-intubating the patient. What are the actions for suspected esophageal intubation? Then you should have to replace the tracheal tube, ventilate through the mask, place a bougie, place a laryngeal mask airway, or place a combi tube, and then finally resort to the failed intubation drill if the above procedures are not successful. What is failed intubation? It is the situation where you can't intubate and can't ventilate. That time you should call for help. Don't panic. Reassess the airway, see the positioning of the patient, reassess the equipment, ensure that there are 2 persons for ventilation, use any other advanced airway or surgical airway is the final. Then call for help. Remember, always check your equipment before you need it. Be prepared and don't panic. Also remember that the patients do not die from lack of intubation, but they die from lack of oxygenation. What are the complications of the orotracheal intubation? That is, during the procedure of intubation, dental and oral soft tissue trauma may occur. There will be hypertension and tachycardia because of the sympathetic response. There will be cardiac dysrhythmias and myocardial ischemia, aspiration and corneal damage. What are the complications of orotracheal intubation in an intubated patient? There may be tracheal tube obstruction, endotracheal intubation, barotrauma, accidental disconnect, tracheal mucosa ischemia and accidental extubation. What are the immediate and delayed complications of extubation? The patient may go into laryngospasm, there may be aspiration, patient will develop pharyngitis, there might be laryngeal or subglottic edema, there can be vocal cord paralysis and also arytenoid cartilage dislocation. What are the alternatives to orotracheal intubation under anesthesia? They are awake orotracheal intubation or nasotracheal intubation, which can be either awake blind nasal or nasotracheal intubation after induction. Then intubation with a fiber optic bronchoscope, where you have awake versus under anesthesia. Then you have orotracheal versus the nasotracheal. And finally is the retrograde intubation. These are the alternatives to orotracheal intubation. That's all. Thank you. Thank you for your patience in hearing. If there are any questions, I'll try to answer. So basically anatomy and
Thank you very much, sir.
intubation in a normal patient.
This is a true teacher who teaches all the students, just like it was in the postgraduate activity or just it is in the lecture hall.
So I have everybody has understood.
Yes, thank you very much for the from basic anatomy of the upper airway that you have elaborated very nicely, and I am sure that all the postgraduate students will be knowing all these things and they will be alert when they will be for the endotracheal intubation.
Anatomy they will have to find out.
Yes. There is no excuse for the endotracheal intubation if you don't know the anatomy of them, and that you have elaborated very nicely, sir.
Thank you, sir.